We're going to go ahead and get started. Just to introduce myself, my name is Ashley Wolfington. I am working with the Interagency Working Group on Reproductive Health and Crises as the COVID-19 Task Force Coordinator. And in the past 6 months have been working to coordinate and collaborate with a number of IWAG colleagues across the globe to develop technical guidance, do focused advocacy, and work together to make sure we have curated resources and tools to help our practitioners in the field adapt their programs during COVID-19 to ensure that sexual reproductive health and rights are ensured during this time. And I think many of you are already familiar with IWAG, and we're not going to spend too much time doing an introduction overview, but just in case people are not so familiar with IWAG, I'm just going to briefly touch on, I'm just trying to advance my slide. Here we go. What IWAG is an international coalition of organizations and individuals working together to advance sexual and reproductive health and rights in humanitarian settings. We're made up of 21 member agencies, plus member associate members, online members, and we have sub-working groups, including and a secretariat housed at the Women's Refugee Commission and a training partnership initiative. And as I mentioned, during the COVID-19 response, IWAG has been doing what IWAG has always done, which is to provide technical guidance and global standards, generate evidence and learning about sexual and reproductive health in crises, and conduct advocacy. And this really has been a hallmark of this particular response, because what we have learned is that we need to amplify sexual and reproductive health needs during this response. And IWAG members have been working to make sure that that has been happening both on the global and country level. So without further delay, I am going to just very quickly make sure that everybody can hear me before we invite our first panelist to the stage. I'm wondering if a brave person could come off mute and just let me know, or go ahead and type it into the chat.
We can hear you.
Wonderful, thank you so much. So as you saw when you signed in, we have a group of really great panelists who are going to be sharing their experiences providing sexual and reproductive health during COVID-19. And I think I'll allow them to also introduce themselves and set the stage with respect to how COVID affected their work and how they responded. So I'm going to, I'm sharing my screen and I'm going to pull up our first panelist's presentation and allow her to kind of get herself off mute and come online with us. And this, Marilyn Nyaboga from International Planned Parenthood Federation, she's going to be talking about how her organization and member associations provided sexual reproductive health services during COVID-19, and also sort of layered on top of that was providing these services also in the face of other humanitarian crises. So I'm going to, trying to come off of this for a second so that I can pull up the presentation. Pardon me. Trying to just close out here for a second. Apologies. Give me a second. Marilyn, can you just maybe introduce yourself while I get your presentation teed up?
Yeah, thank you. Yeah. So I'll go ahead. My name's Marilyn Nyaboga. I'm the Senior Sexual and Reproductive Health Advisor working for IPPF in the Humanitarian Hub. So first of all, I would like to thank the IWAG team for taking this initiative to invite us on board for this very timely and critical conversation. So I'll be welcoming Dr. Hiba from Sudan Family Planning Association into the conversation as well. So before I start my presentation, I would spend around 2 seconds to give you an introduction into IPPF humanitarian work. So for those who may not be aware of what IPPF does. So IPPF is a global service provider and a lead advocate for sexual and reproductive health and rights. So IPPF provides support to vulnerable communities through our global federations of member associations. So for those who are interested to know more about IPPF, please check on our website. Yeah. So Ashley, are you ready with the slides?
Yes.
Yeah.
I am, but I am sorry that I'm just having a little bit of a technical issue. I'm going to press stop and then I'm going to start again sharing. And hopefully that will take care of that. Can you see my screen now?
Yeah, I can see us.
All right, and I will advance the slides. Sorry about that.
Yeah, no problem. So you can go to the next slide. Yeah. So since 2017, IPPF through our member associations have been able to respond to both acute and protracted emergencies globally. So as you can see on the slide, we have been able to respond to a variety of crises around the world that have been caused by either natural or man-made causes. So for example, in 2019, we supported a variety of responses in Venezuela. We also supported Uganda refugees in Africa. There was another crisis we supported in Indonesia. There was a crisis, there was an earthquake and also a tsunami, and also Pakistan drought, among others. Yeah, next slide. Yeah, so while COVID-19 pandemic progressed around the world, some countries experienced a double humanitarian crisis. For example, cyclones made landfall in Vanuatu and Tonga in April this year. Also in India, West Bengal in May, there was also a cyclone. There was an explosion in Beirut that caused a lot of displacement and destruction. So IPPF member association responded by dispatching teams to provide MISP services to the affected population. So they faced a variety of challenges while providing these services, which were related to low turnout of clients for sexual and reproductive health services due to fear of COVID-19 or maybe government restrictions on movement. In Vanuatu, staff had to trek for a long distance to be able to access the affected population, as most of the roads were impassable due to the destruction caused by the cyclone, as you can see in that picture. So members of the association also experienced an increased strain on their sexual and reproductive health resources. For example, personal protective equipment and reproductive health commodities were very expensive in countries where they were available. So this was a big challenge for most of the member associations. In India, there were huge challenges in maintaining protocols for social distancing, which were compromised during evacuation and resulted in spikes in COVID-19 in evacuation centers after the cyclone happened in that area. So all these challenges really affected the kind of response that the member associations were providing in these countries. Yeah, next slide, please. So to ensure the continuity of sexual and reproductive services, IPPF made various adaptations. So the first thing IPPF did was to develop a variety of guidelines to support our member associations in service delivery. So for example, the guidelines we developed included those related to infection prevention and control, prioritization of sexual and reproductive health services. Also, there was one on advocacy messaging. Another adaptation that was done was adjusting staff schedules into different staffs and teams, and also reducing staff working hours. So this helped to ensure continuity of services in case a team had to be quarantined because of COVID-19 infections. Telemedicine services were also provided in Lebanon and India. Lebanon provided online mental health and sexual and reproductive counseling services. They also provided follow-up and referrals. India provided online abortion counseling services. These adaptations helped to reduce the number of clinic visits. So the clients had to visit the clinic only once, and follow-up and support services were provided on phone. Also, member associations used social media platforms like Facebook for sharing general information on SRH. Yeah, next slide, please. In protracted humanitarian settings, member association ensured the home provision of medical abortion through a variety of service providers, either health workers or community health workers. They also partnered with Ministry of Health in provision of sexual and reproductive health services during this pandemic time. Additionally, outreach and house-to-house midwifery services, including doorstep delivery of SRH products for vulnerable women, were provided in Lebanon and also in India. So these countries are also currently interested to initiate hotline services to support affected communities. So lastly, IPPF formed a global multidisciplinary task force to coordinate this response. So they have supported member associations in different ways. For example, with critical resources, including providing them with additional funding. Yeah. So next slide, please. So in terms of key learnings and next step, so some of the lessons we learned, IPPF and MA include the need to continue advocating for provision and access of sexual and reproductive health services, and countering attacks on sexual and reproductive health. For example, in some countries, they have not recognized SRH services as life-saving during lockdown. So our member associations were facing a lot of restrictions from the police and from the government officials, you know, when they were on their way to provide life-saving services. We also need to continue to champion for our member associations to utilize innovative approaches for service provision. For example, telemedicine services. We recommend those to be used for provision of services like safe abortion. Also, another key learning is to focus on data collection and evidence generation. So this is very important because it will support us to, you know, ensure the continuation of these models beyond COVID-19. It's also important also for us to continue focusing on emergency preparedness, especially for high-risk countries, to ensure a quick response during a humanitarian emergency. Lastly, as we adapt, we need to keep a focus on quality, client-centered care, and also offering choice as much as possible to our clients. So we need to balance the two of them. We should not focus on just adaptation. We need to ensure that also clients are able to access quality services. So thank you for listening. I will now hand over the floor to Dr. Hiba to talk about their work in Sudan. Thank you for listening.
Hello?
Yes, Dr. Hiba, we can hear you. Go ahead.
Thank you. Can you handle the slides for me? I'm very grateful for giving me the opportunity to share the Sudan Family Planning Association experience on providing SRH services in crisis setting during COVID-19. Thank you very much. First slide.
Yeah,
first slide, please. There are some
pictures.
Yes, there are some pictures from working in camps in Yala and Al Fashir, which is South and North Darfur. Next slide, please. Sudan context and challenge. Displaced people in Sudan reached 2.1 million by the end of 2019. Continuing violence and disasters, predominantly flooding, also trigger significant new displacement every year. The rates of floods and rains for this year is the highest in 100 years, with expectation of continued rising indicators. More people will be affected by the floods. Registered refugees in Sudan are 1,069,536. From these, women in reproductive health are representing 28%. On 16th of March, Sudan declared a state of health emergency in all parts of the country. Land borders closed, airport continued to be closed for international and national and domestic flights until 12th of July 2020. Travel between states also suspended with partial lockdowns in most of the 18 states, which depends on the positive COVID cases appearance. Since most of the cases are within Khartoum state, the lockdown in Khartoum state is stricter. The capacity of Sudan health system is very weak. With less than a quarter of primary health care center, only 24% offers a complete basic health care package. So SRH services vastly impact beforehand limited capacity PHC services covering with significantly reduced resources. All of it during the COVID-19 response are diverted to cover this response. Next slide, please. Adapting to provide SRH and post-abortion care services during COVID-19. Firstly, the call center service is started with the number 1700. 3 doctors offer counseling services through the call center, contraceptive of any type and obstetrical care. There are mapping was done before the start of call center, and the nearest to the caller's place of residence will be contact the CBS, and she will conduct a home visit and provide the services including contraceptive. Specialized SRH services, consultation, and if needed, the nearest SFBA clinic will be open to the caller, as the staff was on call during the lockdown for all states. Sudan clinic was open most of the time with all precautions measures, but other clinics, if lockdown, during the lockdown, serve on call for the staff. Video sessions on awareness raising recorded in collaboration with Youth Corner and disseminated through social media and SFBA internet sites. The local radio stations also has awareness raising sessions to reach the targeted group. Port Sudan had a session with the chest physician, obstetrician. It was very successful with a lot of participations and repeated more than once during program. There also there was a quarterly and still going on quarterly TV programs broadcasting well-designed messages. Next slide, if you please. We continue on the adapting to provide SRH and PSC services during COVID. North and South Darfur, Khartoum, Gadarif, and Sinnar. These SFBA 5 branches provide services to IDPs and refugees through static clinics, through mobile clinics, and also through outreach teams. Gradually, within time, in collaboration with the Ministry of Health at federal and at state levels, static and mobile clinics and even outreach teams continue providing sexual reproductive health services for IDPs and refugees in those 5 areas. Undertaking the protection measures for the health team and the clients as well. Post-abortion care services also affected by the lockdown. The call center services and even the CBS refer the clients to the static clinic of Sudan Family Planning Association with the on-call staff working during curfews in all states. Next slide, please. From all this, we go through the key learnings and the next steps we hope to implement. The SRH and PAC services sudden discontinue shows the importance of the CBS and telemedicine service. It became a clear goal for SFBA to provide telehealth to care for the clients. SFBA now involving all staff to choose the suitable technology, starting with the call center, and we'll add up soon and going on to improve providing sexual reproductive health services to our clients in remote areas. The call center has been effective at reaching new clients demographic, example men, and also engagement of young women to call about their reproductive health and rights in more free way than when they facing the care provider. We find a lot of comments about this. In our feedback. Using medical abortion services at 2 SFBA clinics continued during the pandemic and needed to be scaled up to all states in collaboration with Federal Ministry of Health. And the meeting is continuing nowadays, and we expect to get permission to provide medical abortion services at all SFBA clinics under supervision of obstetrician soon. Mobile clinics and young volunteers engagement assisted SFBA in scaling up reach in IDPs and refugee camps. Youth had a very creative ways to send simple message to their local communities with local language, and we have a lot of registered videos and radio messages from them. Thank you very much.
Thank you so much, Marilyn, and thank you so much, Dr. Hiba, for sharing your experiences from both from the kind of global perspective from IPPF and especially the way that they have been providing sexual and reproductive health services during COVID-19 with all the restrictions on top of those other humanitarian crises that were described. And thank you so much, Dr. Hiba, for sharing this particular experience from Sudan and showing some very innovative ways in which you used other methods to reach clients during this particularly challenging time. And I know a lot of this is ongoing now. So we'll be really eager to hear from you in the future about some of the learning. And I think as Marilyn mentioned, also seeing some of the data about how the clients find some of these services and if there's more longer term implications to some of what we're learning about different service modalities. So we are going to now shift to our next panelist, who I'm going to invite to actually on the theme of different kinds of service modalities and learning during the COVID-19 pandemic. Manisha Kumar from Médecins Sans Frontières. I'm going to invite Manisha to come on board, and I'm going to stop sharing my screen and allow her to share her screen. And she's going to talk to us about the MSF experience during COVID-19, but even before COVID-19, in really starting to look at some data around client experiences with different modalities of abortion care service delivery. So I'm going to stop sharing my screen now. And Manisha, I think if you can come off mute and introduce yourself, that would be wonderful.
Hi, everybody. My name is Manisha Kumar, and I'm head of the Task Force for Safe Abortion Care at MSF. I'm hoping that everybody can see my screen now.
Yep.
Thank you so much. I'm very grateful to have the opportunity to speak with you all. Good afternoon, good morning, good evening, depending on where you are. So as Ashley mentioned, I'm going to be talking about adaptations to safe abortion care provision, both before and due to COVID-19. So just a brief overview of who is MSF, for those of you who might not be familiar. MSF stands for Médecins Sans Frontières, or Doctors Without Borders. We provide medical humanitarian assistance in poor crisis and conflict settings. Our focus is really on the most vulnerable and marginalized, and in 2019, We worked in over 70 countries around the world. In terms of our activities, our medical activities really fill the broad spectrum of health and healthcare needs. So everything from outpatient consultations, assisting births, including cesarean deliveries, cholera, surgery, malaria, sexual violence, malnutrition, tuberculosis, meningitis. And so as part of our reproductive health work, we treat abortion-related complications on a daily basis. Last year alone, we treated over 25,000 cases of abortion-related complications. And so our rationale and approach to this topic, our reason for being is to reduce mortality and alleviate suffering. So our goal is to prevent the consequences of unwanted pregnancies and unsafe abortion. And in order to do that, we provide a comprehensive package of care that includes contraception, safe abortion care, and post-abortion care. I think most of you already know, but just a reminder, what is safe abortion care? According to the WHO, abortion is safe if the person providing or supporting the abortion is trained. And that, or supporting, is really important. And also if they are done by a WHO recommended method that is appropriate for pregnancy duration. So 2 of those possible methods are an abortion with pills or an outpatient procedure, such as a manual vacuum aspiration. For the rest of this presentation, I'm going to be focusing more on an abortion with pills. So since 2004, MSF had a resolution stating that the availability of safe abortion should be integrated as a part of reproductive health care in all contexts where it is relevant. But what we saw after that resolution is really that very little action followed afterwards. So in this table, you can see that we had quite a few projects with SRH services providing obstetric care, sexual violence care, antenatal care, contraceptive services. But relative to that, the number of projects providing safe abortion care was quite low. So we decided that in order to move from policy to action, we needed a new approach. And MSF created a task force for support to the implementation of safe abortion care in 2016 with the goal of increasing access to safe abortion care and MSF projects via direct field support to 10 pilot projects. So that was kind of the just a background of what kind of led us to really starting to do no test or no touch medication abortions up to 22 weeks gestation back in 2017. So this is an approach that we have been using in accordance with WHO guidance for several years now. So we don't do routine blood tests, we don't do routine ultrasound, and we also don't require routine follow-up. Additionally, the vast majority of the abortions provided by MSF are provided by midwives and nurses. So we often talk about task shifting or task sharing, but I find those terms to be a little bit paternalistic. Midwives and nurses have really been the backbone of MSF's sexual and reproductive health programming since the very beginning. And it is not that doctors agreed that they could share or shift their tasks onto them, but really they were just the best positioned and the best people to be providing this care. So really what it came down to when we took away all of the tests was really 2 people sitting across from each other, sharing information, making sure that we had access to good quality pills and an environment of mutual trust and respect. And so then what we saw was kind of using this no test and no touch approach really increased the number of safe abortion care provided in those 10 pilot projects from 2017 to 2019. And in terms of the outcomes of this approach, we saw that over 3,500 safe abortion care were provided during that time, and the vast majority of them, over 99%, were via the medication method. We've talked a lot about how abortion with pills or medication abortion can really increase access to safe abortion care all over the world, and we absolutely saw that in the poor and conflict crisis settings that MSF works. I mentioned that we went up to 22 weeks. The majority of abortions provided were less than 13 weeks, and about 14% were between 13 and 22 weeks. The total rate of complications using the combined regimen was less than 4%. And the most common complication was actually incomplete abortion, which is tricky diagnosis because it's a diagnosis that depends a lot on the provider's comfort with the normal bleeding pattern that's expected after an abortion, and how likely they are to intervene or prescribe more treatment than not. And what we saw is that with time, the providers became more and more comfortable managing the normal expected bleeding after medication abortion, and then the rate of incomplete abortion actually went down. The rate of severe life-threatening complication was 0.1%, and all this is consistent with the global evidence and data that we have when it comes to approaches that do use testing. So this really helps to affirm that this kind of no test or no touch approach is safe and effective. Similarly, prior to COVID-19, we had started to pilot in certain contexts some more self-managed and community-based models of safe abortion care. So in some contexts, we are piloting working with peer educators, such as sex workers, and training them to provide medication abortion to their peers, as the model and the picture that you're seeing now shows. We had also started working on training non-medical providers, so health promoters, pharmacists, and other non-clinical providers to become supporters of safe abortion care. And in some contexts, we also work in collaboration with different telephone counselors and hotlines, and really coordinating and linking with pre-existing telephone counseling services about medication abortion if possible, and then MSF will be the one to provide the actual pills. So when COVID-19 came and kind of took us all by storm this year, MSF made a lot of adaptations. So similar to what my colleagues at IPPF described, the immediate need for new protocols and guidelines, especially focusing on IPC measures, hygiene, programmatic guidance, about reproductive health and sexual violence care services. But what I want to focus on is really the way that COVID-19, I think, can help to push us move to the next step, which is to go from beyond this no touch or no test, one consultation approach, and really move to more self-managed abortion. So no longer needing to be in a facility, no longer needing to be face-to-face with a healthcare worker, and also getting that information and the pills to the people who need it most. So in line and to help encourage that next step, we developed some self-care and community-based contraception and safe abortion care guidance with template algorithms. So we tried to wrap together providing emergency contraceptive pills, providing contraceptive pills, and medication abortion to really reinforce that contraception and safe abortion care go hand in hand. And the primary target audience for these types of flowcharts and algorithms was really community health workers or traditional birth attendants working in the community, peer leaders or peer educators. Additionally, in some of our contexts, we have been able to do more appointments and counseling over the telephone. In some contexts where we have hotlines for sexual violence, we were able to kind of, when needed, help direct people to safe abortion care services over the phone as well. And then we're also just looking on piloting more self-managed abortion models in specific contexts. Of course, in this process, we faced many challenges. So one of the biggest challenges was actually just the fact that there were multiple competing priorities. As I said earlier, we provide a lot of different healthcare services, as do a lot of other organizations, and of course the Ministry of Health. And especially in the beginning of this pandemic, it was not really clear if reproductive health care services, it was not clear to everyone, I'll say, if reproductive health care services fall under those services that are essential and life-saving. And so that question mark was a real challenge. Another challenge is the lack of face-to-face support to teams. So because of the movement restrictions and the travel restrictions, we have not been able to give the same type of in-person support to our field teams that we normally do when we're trying to develop a new model of care. And in the poor and conflict settings where MSF works, a lot of the refugees and IDPs that we are working with do not have a telephone service, and they do not have internet access. And of course, in a lot of these countries, there's not a functioning postal service. So in a lot of other countries, like believe the United Kingdom started the earliest, and now the United States is following. There's been a big growth in the ability to provide medication abortion via telephone hotlines, and then mail abortion medications to people via the postal service. But those types of resources are not available where we're working, so that's why we're trying to be creative and also thinking about what type of networks do exist. So whether it's, if there's no postal service, can we use motorcycles to transport the pills to women that need them? How can we creatively make use of our community health workers or women's groups in the areas that we're working? And finally, one of the biggest challenges, I think, is varying levels of knowledge and experience regarding self-managed abortion within our organization. So we're a very large organization. Not everybody is very familiar with medication abortion. So the idea that these pills are so safe, that the people can really self-manage this process is really surprising and new for some people. And what goes hand in hand with that is, I think, there's varying levels of provider comfort and kind of giving up the power and control. A lot of times I'll hear, but I just want to call her and know if she's okay, so I know that she's okay. I want to know. And so I think one of the challenges that we face with self-managed abortion moving forward is really getting more comfortable and leaning into this idea of shifting the power and control really into women's hands in more ways than one. And finally, I'll just leave you with 2 more slides. So here we can see the increase of safe abortion care provided by MSF over the past 7 years. What we've seen from 2016 to 2019 is a 27-fold increase in a 5-year period. The number of safe abortion care provided. And a lot of this has really been due to finding ways and thinking of ways that we can deliver medication abortion more creatively via our community networks. And last, I just wanted to mention an online course that's free and open source that MSF created in collaboration with How to Use Abortion Pill on how to provide medication abortion for humanitarian aid workers. So you don't have to be medical and you don't need to pay anything for this course, and it describes how to use and how to do kind of this no test or no touch technique, once again, up to 20 weeks. Thank you very much for your time and attention, and I look forward to the other presentations and the questions and answer session. Thank you.
Thank you so much, Manisha. I did notice there was one question in the chat, but I'm going to ask that we hold all questions to the end, allow all the presenters to come up because some people might have questions for more than one presenter. So I'm just going to ask that we, I will make sure that that question is included in our Q&A session at the end. And also encourage you to just write down questions either on a piece of paper or in the chat box so that we can make sure that we're remembering things from the presentations as we go. I'm going to invite our next panelist, Cyprienne Masaka from IRC in Congo. If you can also come off mute, Cyprienne, and introduce yourself. But I think, you know, what we heard from the MSF experience is really about how even before COVID, a lot of adaptations towards making abortion care more convenient and more client-centered, and during COVID, many of these things that were already being introduced are now more relevant than ever. And what is the learning that we have about that? Cyprienne's experience from Congo really speaks to how to make abortion care through pills more available using a network of pharmacists. So Cyprienne, I don't know if you are able to come on and say hello. I'm going to pull your slides up now and start sharing my screen. I am going to do this. Yes, wonderful. If you want to go ahead and get started.
Thank you, Ashley. I am Cyprienne Masaka. I am working at the International Rescue Committee in Democratic Republic of Congo. I am happy to share their experience about engaging pharmacies and the clients for self-management of abortion care during COVID-19 in the DRC. First, presenting, I ask apology about my English, which could not be fluent, and I believe you can understand me.
We can understand you beautifully, Cyprienne.
Yes, good. This strategy were implemented in 2019 such as a part of our harm reduction strategy to ensure need of safe abortion care in DRC. As we know, since the protocol of Maputo were published in official journal of DRC, we have many needs of safe abortion care where we see in our services. How and why we engage pharmacists in these strategies? As you can see, in normal situation in RC, we have a low user of health facility by people. Less than 20% of people go to health facility when they are sick. More than 40 and 50% lack access to health facility or pharmacies. This can be perhaps because of poverty or physical access to distance with the facilities. But we observe, we note that such in normal situation, 50 or 40% of people go to pharmacies. But in crisis situation, such as DRC has known last year, like Ebola virus disease, and this year, COVID-19, we note that the use of facilities is decreased very, very much. But in the pharmacies, we have seen that the users are increased. We can note that in this Congo, the pharmacy have not more administration that we can offer more confidentiality for user. And the user said that when they go to pharmacies, they don't not less more time, and it is not very expensive. That if we see the services on pharmacies, we can see that the service, the quality is lower. It's lower because of staff pharmacies which are not well trained about drug management, and sometimes they have not a good attitude to offer their service. Sometimes we have seen that drug or medicine are not well kept, and sometimes people don't know that they can find the drug for safe abortion in those pharmacies. So IRC action were to put legislators to count crises and drug management, to train the staff pharmacies about drug management, as in safe abortion we use misoprostol, to show them how correct pathology can be given to the patient, and to have a good attitude before all patients or all women who coming to look for these drugs. This training improves the quality of services in pharmacies, and more clients say that they were very satisfied. We give also supplies, misoprostol, to those pharmacies, and we put a system of mobilization, the person to person, through the community health worker or the YAF and adolescent committee for sexual and reproductive health. Next slide. As we see, the data shows that the use last year in 2019 was lower than the data at 2022. Next slide. According to this data, we learned some lessons and the challenges, such as in crisis situation, such as COVID or EVD, we have acute sexual and reproductive health needs, such as many cases of GBV and unwanted pregnancy, and more unsafe abortion. But in crisis situation, we have seen that the facilities are not visited. But the challenge assessing safe abortion was the pharmacy supporters to offer quality services outside of health center. That the challenge are the sensitization during pandemic. We use mass media, which is helpful, but self-management of abortion requires interpersonal sensitization, which is more challenging with mobility restriction and social distancing in pandemic periods. Another challenge is about availability of misoprostol, because the supply chain is not well maintained. We have a disruption of that because of border closures. Next. Next. This is the DLC experiences what we wanted to share with you. Thank you.
Cyprian, thank you so much. That was a really interesting case study from Congo about how to utilize pharmacies to increase access to safe abortion. And I think you provided some really important also takeaways and lessons about some of the opportunities and challenges that this approach affords. And I think it was also such an interesting complement to Manisha's presentation, because I think it really showcases different ways in which we are really putting women and adolescent girls really in the driver's seat when it comes to self-managing and taking control of their safe abortion care needs, and working with a number of different sort of non-usual suspects in order to make that a reality. So thank you so much. I am now going to invite our team from CARE to come on, and while I get your slides set up, Anushka, Roy, and Hassan, if you want to come on and introduce yourselves, that would be wonderful. And I'm going to get your presentation teed up right now.
Thank you, Ashley, and thank you, IWAG, for making the space for this presentation today. As Ashley mentioned, today we will be presenting together kind of the key takeaways on the impact and adaptations for continuity of sexual and reproductive health services during COVID across CARE's programming. My name is Anushka Kalyanpur. I'm CARE's global lead for sexual reproductive health and rights in emergencies. Others, do you want to jump off and introduce yourselves?
Yes, my name is Roy Asiku. I work as a sex reproductive specialist with CARE Uganda in the Southwest Uganda response. Thank you.
I am Dr. Nazmul Hassan, SRH Sector Lead, CARE Bangladesh Cox's Bazar Rohingya Response Program. Thank you.
Hello everyone, I'm Sylvie Kambu, the MNE focal point with CARE USA.
And I also want to give a special shout out to Chandni Jaiswal. She's our intern for SRHR and is an MPH student at Emory. All right, so without further ado, next slide please, Ashley. So as I mentioned, today we're really hoping to tell a sort of high level picture of the key takeaways that we're seeing from CARE's programming as it relates to SRHR during COVID. So this presentation is really based on, some data triangulation from various sources, and it's really preliminary results. So one of the first key sources is we did a rapid survey with 32 CARE country offices that are implementing health and SRHR programming. Secondly, we've done a deep dive trend analysis of SRHR indicators between January to June 2020 across several projects from key fragile contexts, and family planning, and in some cases antenatal care have been key proxy indicators for consistency. And finally, during COVID, all country offices at CARE have been reporting through situation reports, both in terms of quantitative data as well as qualitative data in terms of lessons learned, what has been working, what's not been working. So what we have here today is just a tiny slice of what is available that we hope to get through in the coming months. And of course, all of this work is really grounded on the leadership and work that is being done by our country offices. Dr. Nazmul and Roy will be presenting 2 examples of that briefly from their context. So next slide, please. First, just to start with, based on the survey, the key challenges and barriers that have really come to light in terms of access to SRHR services is 25 out of 32 countries reported that rumors, stigma, or fear related to COVID-19 was the primary barrier. This has revealed that, it's not just risk communication and community engagement on COVID and accurate information on COVID itself that is a need, but also, as you'll hear from examples from Dr. Nazmul, that it is related to the accuracy of information and addressing myths, misinformation as it relates to SRHR specifically during COVID. Secondly, the lack of PPE for both providers and community members. Of course, for providers, this has been well documented, but early on in COVID, we identified through several country offices, including Chad, where there was a requirement that in order to seek services, individuals had to actually wear masks, especially at the hospitals. And this was a huge deterrent given that at the beginning, community members did not have masks. Third, 22 countries reported that the increased financial constraints. Of course, we know that aside from health and SRHR, COVID has had a significant financial and economic impact. So we are seeing changes in behaviors in terms of uptake of services related to this. Of course, in several contexts, this has meant drop in access to services when, the ability to afford transportation has been limited in addition to services. But in some contexts, like Iraq, where prior to COVID, people actually preferred to seek services in privately run facilities. But now with the financial constraints, we've actually seen an uptake in some of our facilities that are obviously publicly run, that care supports, where services are for free. Next, we wanted to highlight how COVID has resulted in the lack of personnel to provide SRH and GBV services in several contexts. In places like Nigeria, everyone was required during lockdown to show a mobility pass in order to leave their homes. And this applied even to health providers, which was obviously really concerning and impacted their ability to provide services. Similarly, in places like Malawi and elsewhere, we've heard about the diversion of SRH GBV providers to COVID-specific services. I'll hand over to Dr. Nazmul to go into a programmatic example of Cox's Bazar.
Thank you very much, Anushka ji. Thanks, dear valued audience. A special thanks to iWork team for giving me this excellent opportunity. In the headlines, you see two key points: importance of risk communication and community engagement, not only for COVID, but also for SRH topics during COVID. And adolescent services are disproportionately impacted. Out of more, I want to share only two key learnings from Cox's Bazar. As noted on the slides before, rumors and misinformation have played a key role in impacting SRH services during COVID, including in Cox's Bazar. In fact, we know that religious beliefs among the Rohingya communities results in concerns that if they die with foreign particles like IUD or implant, that they will be denied of a proper Muslim burial. Therefore, as you can see, there was a sharp decline in uptake of LAT services and in fact, increased demand for removal during this time. CARE is now working with BBC Media Action to address this situation. And number two is, as you can see, adolescents' access to SRH services are disproportionately impacted by COVID. You can see that the drop in both family planning and NC services is much greater for adolescents compared to adult women. Secondly, you can also see that after the initial period, during recovery, adult women were able to increase uptake more quickly, with adolescents still lagging behind, indicating the greater vulnerability of adolescents. The next slide, please. Thank you. Now I want to discuss some key adaptations to ensure continuity of SRH services considering the ground reality. Care Bangladesh delivers SRH services through 4 static health posts and 14 SRH outreach mobile clinics teams in Rohingya camp number 11 to 16, and through community level awareness. During COVID, in order to ensure continued access to SRH services in line with MISP, Care Cox's Bazar implemented some key adaptations to support women and girls in this context. You can see on the slide a few adaptations. Initially, we saw a drop in uptake of services. Providers were not comfortable due to lack of PPE and training. There was a scarcity of PPE around the country at the time. Community feared seeking services, so we dropped in services. To address this, we mentored our frontline service providers and trained them with different types of training and gave them appropriate PPE immediately. We have collaborated with the SRH subsector and different sectors working here, like health sector, community health worker working group, communication with community working group, etc. Enhanced outreach by mobile clinic adapted with more restrictions on mobility. At health facilities, adapted patient flow and testing available and referral. Established hand washing facilities in front of the health posts. Adapted awareness approaches. Here, we adapted with 3 risk communication and community engagement. Number 1, increased door-to-door visit by maintaining social distancing. Number 2, increased individual counseling by using approaches through collaboration with CWC, that is communication with community working group, who published IEC and BCC materials in all 3 languages, English, Bengali, and Rohingya languages. And most of the IEC and BCC materials are pictorials and approved by the government. And number 3, awareness raising among people in waiting space of health posts, increased community engagement and arranging community sessions not more than 5 persons at a time by maintaining social distancing and providing PPE to them. We also adapted with government instructions for the mobility of frontline service providers by ensuring their health, safety, and security. Thank you all for your patience. Thank you very much.
Next slide. Yeah. This row, I'll be to what Uganda Care International in Uganda has done during this COVID, how we're able to adapt and also continue with the services during this COVID. Yeah, for social productive health among the refugees. I want to say that Uganda is a host to over 1.4 million refugees, mainly from South Sudan and the Democratic Republic of Congo, spread across South and West Nile. Yeah, prior to that, we were engaged in the refugee community and the host community, not to got the first case in March. This hit both the refugees and the host community, and this has impacted greatly on the quality of services and the engagement of the people in the refugee settlement. Yeah, we engaged the duty bearer among the refugees and also the service providers, and were able to use the community social groups and we empower them to claim for their rights. They engage the service providers, especially health service providers, to respect the rights, and this did it, and we empower the community. And by the end of the lockdown, the social groups that we established are able to, advocate at community level, advocate through the groups elected parliamentary representatives in the local councils. Next. Yeah, between March and April, May, we did a rapid assessment to ascertain the SRHR services across the settlements and also across community as part of the social accountability and rights-based approaches. And as you are seeing in the slides here, overall, quality of SRHR services declined between January, February, March, and this really had a very big impact on women of reproductive age. As you are seeing, 58% were affected. Then we have about 34% who were feeling unsafe to access services from the health facilities, be it in private or public facilities. But then among the refugees, this is made, and moving out of this how somehow restricted. However, I should say that we're able to engage the duty bearers, the elected representative, the district task forces, for continuity of services. And therefore, you see that we used locally led solutions, and by May, services drastically increased, and by June they continued, and as of now, the status is changing. So we feel that using the social accountability and incorporating it in the other approaches or the pillars of the response, we're able to adapt during COVID. Next slide. Yeah, what do we do as Care Uganda? Just like I mentioned, we cannot only address the issue of the COVID without using innovative approaches. So using the social accountability and rights intervention, we're able to adapt. And we found out that through engaging the local councils, the social groups in the community who are able to know their rights, they're able to continue to create information in the community. And by this, we're able to gain what? Acceptance in the community. The district task forces are able to take on the issues, SRHR being essential service. At the start, these ones were considered as what non-essential services. They were not emergency. But through the social groups, we were able to advocate for the task forces to ensure that the SRHR services are considered as a what? As a critical service. To adopt it further, we were able to promote services remotely. We worked with the health facilities to ensure that the ANC and PNC and FP services are done remotely, just like other countries were doing, using telemedicine, using the VSTs to take these services to the community. That structure we strengthened it, and also the social groups were using them to deliver more products to the community. So peculiar that is that we had to modify the way to reach the community, and we used the motorcycles. Motorcycles, these are two cycles where we unload a speaker with recorded messages on the people passing roads, on the refugee roads, and they move with these messages in the settlement. And also we use the social groups they use megaphones to disseminate more information in the community. And then I should say that at national level, through the engagement of the district task forces, we're able to raise the voices of women. We worked closely, through the elected representatives of parliament, women representatives, the ones in the district, to advocate the issues of women. We recorded increased cases of SGBV during this period, but then using elected and influential women in the community, we're able to bring the issues of social accountability, issues of SRH being important in the community. And also I should say that at national level, through the district task force engagements and also using our social groups, we're able to strengthen referral system. You know, where there were no ambulances, through the protocol leaders, they continue to engage the president and the office of the prime minister to ensure that every district, especially refugee hosting districts, have and council ambulances, so that women who have cases are supported to go to the next facility. Using also the motorcycles, they were allowed at the initial stage. They were banned to move in the whole of the country. In the settlement, even was worse. But through the advocacy, were able to, enable them to do. At health systems level, we were able to do capacity building, strengthen the supplies side, and also empower the village health teams. Yeah, that's how we're able to. I hand over to my colleague.
Thank you, Roy. Next slide, please. The Support Access to Family Planning and Post-Abortion Care Initiative, as many of you know, in normal times, take a nexus approach to health systems strengthening in fragile contexts, including preparedness efforts and acute emergency response. During COVID, although we've noted some drops due to COVID for various reasons, like stockouts in DRC, due to mobility restrictions and border closures, and also mask requirements in Chad, as mentioned, the key takeaway from this slide is actually that we have continued to meet and actually surpass all our targets in all 3 SAFPAC countries despite COVID, even though the targets were developed based on historical data. This brings us to believe that programs that heavily invest in preparedness and have experience in working in emergency contexts, including DRC, which recently completed Ebola response, are more able to pivot quickly for adapted approaches and helps to make the investment case for preparedness efforts on SRHR. Thank you, and handing over to Anushka.
Next slide, and this is our summary slide. So essentially, as my colleagues mentioned, we have several key learnings that have come out from our work globally. Including in the survey, we've seen, items that other presenters mentioned today around digitization and remote approaches to ensure continuity of services for psychosocial support, SRHR, as well as communication, including to monitor commodity stockouts within the health system. We've seen several countries scale up their work around cash and voucher assistance to overcome financial barriers. As Roy mentioned, accountability approaches and rights-based approaches it's clearly not only feasible, but also critical in a context like COVID. We've really been able to leverage and empower the work that community-based groups, and in particular women's groups and youth groups, have been leading. We've seen this in things like risk communication and community engagement, but also even in the production of masks. As Dr. Nazmul mentioned, this data has been very clearly stating, not only from Cox's Bazar, but also from Uganda and from Nigeria, that targeted approaches to meet the needs of adolescents is really crucial. Mobile services and advanced outreach teams have really been able to increase uptake and ensure continuity of services. We've seen this in the Sinjar Mountains in Iraq. We've seen this in Butembo and DRC. Another 2 key points. One, COVID-19, just like Marilyn and the IPPF team mentioned in the beginning, is just one layer of things that fragile contexts are dealing with. We've seen insecurity, we've seen other overlapping crises as also contributing factors. So just one, a really key takeaway there. And finally, as Sylvie mentioned, we feel that this information is also really clearly stating and making a case for investment in SRH and pandemic preparedness. In the interest of time, we will pause there and looking forward to some discussion. Thank you.
Thank you to the CARE team. A very comprehensive look at some really key lessons, lessons learned and sort of successes from a variety of contexts that already had very difficult challenges as far as provision of sexual and reproductive health services. I am going to now ask that all of our panelists be on standby for any questions that we might have from the rest of the participants. I think while you can go ahead and type them in the chat and I can moderate them there, or feel free to ask them directly, come off mute and direct any questions directly towards our panelists. I think just to get us started, I'm going to revisit a question that was directed at Manisha from MSF related to her presentation on abortion care using medication. Specifically, Megan is asking about the algorithms. She says the algorithms look great. Could you elaborate on how these are used vis-a-vis counseling? For instance, it looks like they assume the client does not want to become pregnant. So that intention would have already been established. Manisha, would you be able to address that question?
Yeah, absolutely. Thank you so much for the question. So for the algorithms, we really wanted to try to keep it as neat and simple and straightforward as possible. Obviously, counseling is an important component, and we kind of have a separate tool for that. So the algorithm can't be used in isolation. We also have a medication abortion flip book, which is an image-based book that uses very few words and is very picture-based to help guide the provider or the supporter through the various stages of the abortion counseling process, which of course includes talking about what does the woman want for this pregnancy. So yeah, I hope that answers the question. Thanks.
Thank you, Manisha. Any other questions from to our panelists from any participants? You can just unmute yourself or type anything in the chat box. I have a question here from Kate Ramsey, and it's directed to CARE, but also could be for others. How many of these practices were specific to COVID and wouldn't continue, and how many would you consider to be more long-term shifts? So, CARE, I don't know if you want to take that first. Some of the practices and adaptations that were described. How many were specific to COVID and maybe will end, once the pandemic is over, and how many would you consider to be things that are longer term shifts and might be more, just now will maybe be a continued a standard practice?
Roy, Dr. Nazma, would you like to start? If not, happy to jump in. I can get started.
The question, please, because my network was disturbing. Can you please repeat?
Sure. So the question is really many of the practices that were described, how many were specific to COVID and would not continue? And are there others that you would now consider to be more permanent shifts in the way that you do your work. And
Yeah, some example I can
thank you.
mention. Can I say?
yes, Nazmul, go ahead, and then others can jump in.
Yeah, thank you. Some examples, here there is a specific instructions for Rohingya camp, because in our national levels there are some circulations to follow for the host community, but for the Rohingya camps there are some special instructions that is managed by another government authority here. So we followed their instructions, like for the mobility of the staff to the camp, because camp is around 1.5 hour distance from our office. So every day the staff are moving, frontline staff are moving. So they have to maintain the social distancing and personal distancing during traveling to the camp. And we have increased our number of vehicles to maintain that social distancing. Number one. And number two is that some other problems, that is there are some misbeliefs across the community. So the service providers, those are residing in the different areas nearby camps and our office, they were also hear some things from the host community that for them they would get COVID. So that we have to manage the host community, that we are for them, we are working for them. First type of psychosocial counseling we are doing for the host community as well as for the Rohingya community. And in the outreach services, we allowed only one person at a time to take their services. But earlier, the many persons at a time, they come to take their services. And outside the outreach services, we put some Rohingya and host community volunteers. They also maintain the social distancing. And in the health post, at the same time, we allowed only 5 persons by maintaining the social distancing, and they are waiting. And at that time, we are counseling them. We are providing them information about the COVID related services. And for any community meeting where we are arranging, it's not more than 5% at a time, and we are providing PPE, that means personal protective equipments, especially the mask, and arrange the discussion like that way that social distancing, personal distancing will be maintained. Like that, we are providing the services. And initially, it was a big problem. But now, as we are working and engaging the community and risk communications, we are taking and collaborating with the different agencies working here, so that it's gradually decreasing.
Great. Nazmul, thank you so much.
Sorry?
I just wanted to, sorry to interrupt, but I just wanted to make sure that I think Roy was also coming in with an example of a particular maybe COVID related shift that might actually have a more long-term, might have a more long-lasting impact. Roy, were you trying to come in with something? Maybe I was imagining it. Okay.
Yes. I think one thing that, yes, I think one thing that was specific for COVID. Are you getting me? Yeah. So I was saying that one of the things that was specific to COVID was the engagement of the health unit management committees to adhere their rights and their responsibility in management of the health unit in the health service delivery. One, IPC became a core, and therefore it's very important for the service providers to engage with the responsibility holders that COVID does not spread. And also maybe second issue that we need to take on as a long-term intervention is the policy engagement through the district task forces and the
Oh, I don't know about you all, but I have lost Roy. I wanted to give Marilyn an opportunity. She had, I think, also had something she wanted to add on this topic. Marilyn, do you want to come in?
Yes, yes.
Great.
So I want to contribute to this discussion
Yes,
on,
thank you.
yeah, these methods were being implemented before COVID. So I would say they were there. Like, for example, telemedicine services were there, but they were not very popular. So I think with the government restrictions of movement and all these challenges that have been happening around COVID-19, I think, yeah, everybody was interested in these methods, and also the clients were very responsive. So yeah, so one good example of a win situation for telemedicine services, for example, in Nepal, where abortion services were only allowed to be provided in the clinic. But because of these government restrictions, the member association was able to negotiate with the government to allow abortion to be provided at home. So, you know, they had to approve, and, you know, the government, the Ministry of Health, in partnership with the various organizations, developed guidelines, yeah, to support this implementation. Yeah, thank you.
Great, thank you, Marilyn. I realize now that we are over time. There were a few other questions in there, which maybe one of them we can maybe just take very quickly, which was related to the way that you were directed at Manisha from MSF around how does MSF count the number of women receiving the service? Do you follow up each woman who received medication abortion pills, whether they used successfully? So maybe Manisha, you can just take that as our last question. I see some nice chats going on, but maybe just if you could just take this last question and then we'll wrap up.
Yeah, so for MSF, we decided to stop doing routine follow-up for our patients undergoing medication abortion, whether they come into the facility and receive like a no-test medication abortion, or whether they receive their abortion via one of these more self-managed abortions. Experience from a lot of other organizations and people who have really been championing self-managed abortion for quite some time now really shows that if women have a question or a problem, they will come back and they will contact you again. But because medication abortion is so safe and so effective, the vast majority of women don't even come for their follow-up appointments. And that's true all over the world because everything was fine and they're not having any problems and everything went really well. So no, we do not follow up on every single woman individually, but the fact that they were able to access our care once, you know, we know that they will be able to access it. They're more likely to be able to access it again in the future if needed. So it was really about trusting in the safety and efficacy of medication abortion, and also trusting in our patients, and really highlighting that in case of any problem or concern, of course, they can come back and speak to us, but that it wouldn't be routine or systematic. Thank you.
Thank you so much for that answer, Manisha. And I think it's a really great note to end on. And I think putting more trust into the hands of our clients, listening to them, what they need. I think one of the things that was coming through in the chat, and I think speaks to the heart of many of the presentations, is really that there were a number of different client-centered approaches that were being tried or introduced before COVID-19. And I think during some of the, with the restrictions on movement and mobility, a lot of these approaches, I think, really gained a lot of popularity and support, and I think have a real potential to then be long-lasting changes in the way that healthcare is delivered to our clients, and in ways to improve the way sexual and reproductive health and rights are ensured in humanitarian settings and beyond. So I just want to thank you all for sharing your experiences from, from all over the world, from Sudan, from Cox's Bazar, from Uganda, from Nepal. I just, from DRC, I'm working with the pharmacies. I just want to thank you all for sharing these experiences. And I hope this is just the beginning of a dialogue that we can have about which of these approaches we really want to invest in, see more long-term changes to ensure sexual and reproductive health and rights in humanitarian settings. So thank you all so very much. We have recorded this session and we have also the PowerPoint presentations, which we can make available if our presenters agree. And I just want to thank you all so very much for attending and giving us an hour and a half of your time today. Thank you, and thank you to our panelists. You were all so excellent. Thank you so much.
Okay.
Thank you.
Thanks, everyone.
Bye.
Bye. Thank you very much. Good night.
Bye.
Thank you. Bye bye.